All right. Well, let's go ahead and start. I'll wait, a second for him to get his camera on. But welcome, NUR203 Pediatric Nursing. My name is Professor Bogart, and I have been with the Fortis population since 2017. I started out working on ground at Cutler Bay. I taught pharmacology and I taught pediatrics. I also did 1/4 of community. So I've got a little bit of everything in me. I also help many students with med surg and understanding concepts, because if you think about it, pediatrics and adults, there are a lot of the same concepts. When you talk about respiratory distress, you're going to be talking almost the same thing with a little bit of differences in pediatrics to adults. So I can help you with that, okay? So I have been a nurse for forever, since 1976. You believe it? I'm going on almost 50 years. And I absolutely love nursing. I love every part of it. I've always been a teacher. I've always been a mentor. So you get to have me to help you hold your hand when you want and to help you through. All you have to do is ask, okay? How do you get a hold of me? Well, if you look at the about your instructor, in fact, on yours it says Professor Bogart on your module page. It has my cell phone. Yes, you can text me, you can call me, but use the text and calling me when you're having a moment and you need to know it now, or it's something that I got to know an answer. Okay. If not, send me a message. I do check my messages, emails. I can't even tell you how many times a day, quite a bit, and up to almost to the time where I go to bed at night. So you really have me watching over you and getting what you need pretty around the clock almost. So in pediatric nursing, the only thing I request from you is if you don't know something, you ask. Okay. If something is going wrong, you can't get something done, ask before things are due. And if you do that, I can help you. I can waylay your assignments being due because you were in the hospital, your daughter, your dog, your neighbor, a car accident, whatever it is. Tell me before something is due, and I can help you succeed a little bit better. Okay. So, how do I teach? Well, I don't know. Some of you have heard about me. I'm going to teach on a PowerPoint. I don't read it. Okay. I'm going to look at it, say, oh, this is what I need to say. I'm going to tell you about it, and I'm going to give you some little scenarios that I remember from just being a nurse for so long. And I'm going to make that concept more understandable by giving you my little stories about my kids that I absolutely still remember and still love till today. Then, when I'm done, I do a Cahoots. Now, the Cahoots is an immediate testing on the knowledge that I just gave you. Those Cahoots have all the concepts that you need for quizzes, exams, and you'll even see them on the HESI. So they're very, very important things. Students get together, they start quizzing each other, and I think it's a beautiful thing because I will post all Cahoots on the announcement with the recordings after week 1. You're going to see 2 types of announcements from me weekly. Be week 2 information, week 2 recording. Week 2 information is the PowerPoint or any information handouts you need. Then week 2 recording, I'll redo the Cahoots. I'll repost the PowerPoint and anything that I said I would give you. Let's say what's going to give you more about dosage calculation. It will be there. So those 2 you'll see every week. So to look out for that. If I send you another announcement, it's because it's very important. I don't send out 16 announcements a week. You have 3 courses, most of you, and you don't have the time to look through all of that. So if I'm sending you something, please look at it, okay? Because I know it's easy. Oh, it's her again. And you don't want to look at that announcement. And I get that. I understand it. Your time is precious. So I'm going to go ahead and start with there's 2 PowerPoints we're doing today, and maybe we'll get to the Cahoots. Now, there's something I ask before every term. I can go completely through and I can do the course and get you out early, okay? Or we can take a break in the in between. No, if you need to go to the ladies' room or men's room, go ahead.
Early.
I
I vote
get
early.
I understand it. Also, if you need to eat, I don't mind. I get it. Some of you are running from work, running from another class. You don't have time. Please have something to eat. Just don't have it down your face or, whatever, so everybody can see the way you're eating, okay? But I don't mind. I get it. I understand it. All right. So is everybody just to get out early, go straight through? There's a slight pause between the PowerPoint and the Kahoots because everybody's got to get on. So that's like 5 minute maybe. So that's, if you need to get up and run, all right? The one thing I do request is cameras on all the time and not on a ceiling fan. So, Abraya, more of your face, not a ceiling fan. I don't like ceiling fans. And Heather, I need also your camera on at all times. All right. And why do I like that? Well, number one, I know you're there. But number two, I can see your faces and expressions. And it's like, oh, they don't get that. Let me explain it a little bit differently. Okay. And that's why I want it there. So let's go ahead. We'll get through. If anybody needs anything, you just let me know. You can stop me at any moment. I don't get offended. I don't get upset. There's nothing I'm not going to hurt you if you want to do things like that. Hold on, let me get it back up here. Here we go. I got a new computer and it's very touchy. You know how those are. Anyway, so this is the PowerPoint you're going to see in every class. They're a little bit different, different colors, but I'm going to go through it pretty quickly just to let you know what I want. So again, we know that online is difficult. You're at home, there's a lot of distractions. Also know that you'll be getting recordings every single class. Usually it's right after class. So you end by 5:30, by 6:30, you usually have the recording and all the information. I like to get it to you as quick as you can. Some of you study right away and some of you don't, but at least it's there in case you need it, okay? Now, first of all, if you need to get a hold of me, send a message in the Canvas, or you can text or call me if you need to, all right? If you can't get a hold of me, I'm the lead professor, so there's no lead to go to, but you can go to Dr. Brown. It's okay. You can report me. It's not going to hurt me. If you need help, it doesn't matter to me that you have to go to Dr. Brown and say, I don't know what's going on, and Professor Bogart, whatever. Okay. We're here to get you to succeed. I don't take it personally at all. Okay. Usually I'll answer, but who knows? Maybe I'm having a bad day. We all have one of those. Now, Dr. Brown, here's her email and here's her phone number. If you need it, email her or please make sure you call her. She doesn't sleep at all, I don't think. And she will get back to you fairly, fairly quickly. Etiquette and civility is always something that we need to remember with each other. I know that we all get upset and angry and frustrated, but let's not take it out on each other, okay? Let's work together and let's make an agreeable understanding what's going to happen, as in no big type, cap messages, et cetera, all that good stuff. Now, the first week, you have to go through all your welcome posts and all of those things to open up the modules. And then you're going to see that there's a discussion question. The first one is due on Wednesday by midnight, and then 2 peer posts by Sunday. Now, I've been asked, can you do it all at once? Yes, you may, but get the most out of that discussion question as you want. There's some professors that say discussion question, then you have to wait till the next day in order to do the peer responses. If you're seeing peer responses that something you want to respond to, do it. It's okay. I don't, get that picky with it. What I want to see is that you've answered it and that you're thinking about it, and then you're responding to another student's the way that they think about it. Okay. All right. The one thing about academic integrity, there has been quite a bit of problems with this, where there's cheating, there's plagiarism, there is going into other sites and copying information. They are very, very aware of this at Fortis, and they are monitoring these sites like crazy. So be careful, don't do it, okay? What I say is if you need to cheat and if you need to plagiarize, what's going to happen when you get to that NCLEX? You're not going to pass. Number two, if you get to a patient, what are you going to do? You don't understand what you have to do. So I am not an A nurse. I didn't graduate with a 4.0 at a nursing school. Would you like me to tell you what my GPA on graduating nursing school was?
Do
You'll be
it.
shocked. 2.28 GPA. I just made it by. But
Jeez.
BSN, MSN, PhD 4.0. Okay? So it's because I don't test well, like many of you. So I made it through and I passed my NCLEX because it was my hard work. I didn't do anything to, enhance my grade. A does not equal RN. C and above equals RN. Okay? Code of ethics again, just make sure that we are doing what is right. Okay, that's all what we're talking about here. They've been monitoring that Sudoku, Course Hero, Stuvia. There's many more too. They're monitoring them closely. Again, I'm warning you, don't do it. Do your own work. I will help you with those projects. Send it to me early and I will help you get that 100 out of 100 on it. But you've got to send it in early with me, okay? I do work with you. Now, you have till Sunday night to get, let's say, the discussion question done. And let's say you don't get it done because all of a sudden you're in a GI problem and you feel terrible and you can't hold your head up. Shoot me a message. Professor, I'm really sick. Can I have till tomorrow to do it? Well, it's not midnight on Sunday yet. So, yes, I will give you that. So, again, how many times can I tell you? Communicate with me and I can help you. Now, if it's nobody's called, nobody's sent me a message, the homework is due midnight on Sunday. Now, the second week, it will be a minus 10% deduction. It's better to get a minus 10% deduction than it is to get a zero. I had one student that almost last quarter failed because of homework. She didn't get all of her homework in. It was 0.01 she passed by. Okay. So be very, very careful. Get your homework in. It's better late than nothing. Once it's after 7 days late, I cannot accept it unless there is a note, an excuse, a reason that I've heard of before it was already overdue. Okay. When you come in, as I said, I want your name, I want your campus, put it there. Remember, at 3 o'clock, you still get full credit. At 3:01 Eastern time is when it'll be 15 minutes late, okay? I'm really careful with attendance. I try to make sure that I put it in correctly because I know 20% comes really easy. Do you realize each class is over 8% of your grade? So two classes and a 15-minute here and there could be 20%. So be very careful with attendance, all right? If you miss a class due to a reason, send me the doctor's excuse, the court order, the accident report, the whatever. Give me documentation and we can justify why you were late. And then send them to Dr. Brown, and then you're not going to have that 20% come up on you, okay? Make sure you're not in the car, passenger in a car, driving a car. I cannot have you on camera then, okay? And I will remove you from the class. Dr. Brown is extremely, extremely strict about that, okay? Remember, if somebody is not coming to class, if there's 2 days, 2 weeks in a row that you don't come and do an attendance, you can be dropped without any notification. That's why week 12, you had to show up for your professor last quarter. All right. If you had it online, you got your week 12 attendance just in case week 1, you didn't have it. Now you didn't have 2 weeks in a row. So that's why the professors were like, where are you for your attendance? Okay. All right. We know about that already. We already know all about 20% and bringing it down, and you'll get letters as you go 5, 10, 15%. So, how to succeed? Every week, I'm going to tell you what is due. All right. Making sure that you get them done. You can do discussion questions early. You can do NCLEX questions early, but CJ Sims, no. Those will be done on the time when they're supposed to be done. That's a question I always get from my students. What can I work on quick? I have a lot of classes. So I do have a couple of them open for you, but you cannot do your CJ Sims early, okay? On the NCLEX questions, first week is not under pediatrics, it's under growth and development. All right. And then you check the boxes, infant through adolescent. And those are where you're going to do your NCLEX questions. I will have one student in this class that sends me pediatrics, and I do check to make sure that you're doing the areas that you're supposed to do. You know, all assignments, yes, they're due when they're due. Check these things. If you see, again, an announcement from me, read it. Um, when you come to class, make sure your computers are plugged in. When you come for your quizzes, your exams, make sure everything is plugged in and it's ready to go. If you're taking your, exam at home on Zoom, which we will do, make sure that it's in a place where the kids aren't running around you and jumping on your lap and not letting you think, okay? And I know it's hard sometimes. I really do. Make sure that you do, you go to the about Professor Bogart, write down my cell number, have it in your phones. And I'm going to tell it to you right now so you can do that right now. It's 305 951 8055. That way, everybody always has their phone on them. Okay. Where's the phone? You're not leaving without it. So now you have my phone number. You just text me a message or call me something, something, so that it'll be easy accessible for me.
Can you say that number one more time?
305 951 8055. Always make sure you have your core syllabus. That's our Bible. That's the way everything is set up for the assignments so that you can follow with it. But I've also said every week information should be coming out on Sunday, usually at midnight on Sunday, Saturday night into Sunday, and you'll have all what to do for that week. Okay. Again, any problems, let me know. All right. Now, you should come to class and you should have looked at the information that we're going to be discussing. I know sometimes it's not possible. It is the ideal thing to do. What I say is you come to class, you've seen it, I teach about it. Now I've given you a cahoots. That should be 3 times you've looked at this information because that repetition of information will help you learn a lot better. Okay. Now, I don't do per se weekly reviews. What I say is if there's a concept, something that's going on that you don't get, don't understand, send me a message and I will work with your schedule so we can meet. I don't take 2 hours on Zoom with you. I understand your time's easy. So don't think once you come to Zoom, I'm going to be there for an hour. She's not going to let me go. No, I'm not like that. All right. You come to me, we discuss the concepts, anything else you need, and then you could go on with your way. But I work, from morning to, I don't like early mornings, to tell you the truth. That's just not me. I'm not a morning person. But anything all day long into early evening, I can do and I can I'll meet with you to help you, okay? Tutoring, I'm always here, right? I know that before exams, the first exam, many students don't come to me and don't want to go over a review. And then they get their, grade and go, well, maybe I should. You can come to, as I said, for exams, every single pediatric professor will be doing an exam review. It's on the PowerPoint that I make, okay? And I make sure all the concepts that you need are there. All right. After you've watched mine, and I suggest at least one more. So you watch 2, and there's still something you don't get. make an appointment, and I can go over what are those concepts that you don't get, and I can help you with them. Okay. And I know people who do that do a lot better. KGA, same thing. Unit exams, quizzes, and your HESI. All right. And then there's 20% of homework. Now, make sure with the homework, don't just get it done and don't have a passing grade. Don't do that because that 20%, I've seen many students fail on homeworks. They passed the KGA with an 80 something, and now they don't get their homework in, they fail. And I don't want to see anybody do that. You will get reminders from me, a lot of reminders. Now, initially, homework grades are turned on, off, and then on week 6, I turn them on. I'm showing you how homework grades do affect your grade, either positively or negatively, but they affect your grade. On week 8, I turn them off, and they will not be turned on until after the HESI, after all the remediation, and that's your final grade, okay? I can't turn on just one student. It's the whole class or nothing. So you know you need a 78 on KGA, and you know you need to have the homework go in and still be above a 78. So exams and quizzes. Remember, on quizzes, I don't have you come in on a phone. I do a quick check over on you. But for exams, you need something to come in on Zoom, and then you need your computer to do the exam. Make sure they're charged, okay? I can't tell you how many students their batteries died, or oh, I got a quick run. My plug is in the car, and they have to stop the exam and run out. And I don't really want that to occur. And if you have your stuff charged and you have your cords with you, you should be good. Because if you are not on camera during quiz or exam, it's a 0. So you can't just all of a sudden go to a quiz and do it and not have been on Zoom with me because that's unproctored. And that will be a 0 on that exam. All right. There is only one attempt on the quiz. It's only forward. And if you're not here for the quiz, you cannot retake it. Once the quiz is done, and I do them at the beginning of class, and I do it on last week's material. So week 2 is a quiz. So guess what we're going to be doing it on? The PowerPoint I'm showing you today. Okay. And the Kahoots I show you today. So that's what you're going to study and for the quizzes. All right. As in, quizzes cannot be made up for any reason. Exams, again, same thing. Make sure that you test your equipment. They are, I believe, have looked at Chromebooks and iPads and whatnot to make them more accessible. They used to not be accessible to Exemplify, and now they've made them so that they can be used because many students had Chromebooks and or had just an iPad. Okay. Now, again, exams are 2 devices, etc. Make sure that you check the Exemplify, etc before you come in for an exam. Now, what happens if all of a sudden there is, some of you live in areas where there's going to be snowstorms or there's big thunderstorms and all of a sudden the electric computer goes off. Send me a text message. Computer just went off, big thunderstorms. Stop what you're doing. Don't, even if you can get on there, stop it, exit out, tell me. We can always restart a quiz. I can always get exams off to restart your exam where you left off. Not from the beginning, but from where you left off, okay? So if something, don't get upset. Don't like, oh my God, it's lost. No, exams don't get lost, all right? They'll always be there. Just let me know, all right? Anybody with accommodations, I need to know before next week, or else the quiz is not going to have extra time. I especially need it before the first exam, which is week 4, okay? If you have accommodations, I got to work with you. When do you want to do it? You want to come in early, or you want to do it another day? What do you want? I'll work with you, but you have to let me know. I need that letter from the national dean, okay? Dr. Foster. I need her letter so that I can make sure, all right? We know that when you do your exams, I'm going to want an ID, whether it's Fortis or your driver's license, and I'm going to do a complete review and looking at that. Nothing on your head, unless it's because I had one student several semesters ago that she had surgery, brain surgery or something, and she had a cap on her head. She had a doctor's excuse that allowed her to wear the hat on her head, or unless it's religious, that's fine. You can wear those things. I just need to know those things because nothing on the head, because I'll be looking at ears and all of those sort of things. If you need to miss an exam, I need to know before the exam starts. Okay? I'm in the ER, or I have such a severe headache, I can't think. I have a migraine. Let me know before, and I can reschedule it for you with no deduction. If the exam starts and I'm sending you a message, hey, what's going on? Where are you? That's going to be a minus 10% deduction. I don't want to do that to you, but it's better than a zero by me asking you. Okay. So, and also, there are some students here I know from a campus that does a lot of on-ground testing. Let me know who's going to be doing your proctoring, and that person who's doing proctoring also has to email me, and I'll send them the access code. It should be given at the same time as class as we're doing online, okay? And I don't mind. I work very closely with these campuses. Again, talk to me before. I want to see everything before. We know the quizzes are out of your modules. You click on them and you go. And again, any problems with um, getting access or something freezes or whatever, let me know. Just turn it off and I'll work with you. Don't worry. HESIs. HESIs usually are on campus. Be aware, I have no control of when, what time, nothing. HESI exams can occur anytime in that HESI week, and it's scheduled by the campus according to when they have rooms available, right? So HESI exams, don't ask me. I don't know. If you want to, I can ask the dean for you or the campus, but that will be something they usually schedule closer to the HESI, what day and what time. Many of them try to get it close to the day and the time. But remember, pediatrics is Monday, Wednesday, Tuesday, Wednesday, so Friday. So when is it going to be? It all depends, right? Remediation, you just went through it. Those are the hours. I'll be sending you an announcement to tell you those things again. So you don't have to remember or think about that. I want you to know that I usually on my HESIs, my mean HESI score overall is greater than 900. So if you do what I tell you to do, you come to my HESI review before the HESI, and you do the cahoots I tell you to do, because I have another 100 set for you, you're going to do well in the HESI. But again, this takes practice and going throughout the whole quarter and understanding what you're doing. We know all about exam things, of course. We keep saying the same thing, right? So again, doing all of your homework, we know 7 days, you'll get your full credit. After that, it's minus 10%. Now, NCLEX questions, like I said, they are, the first one is growth and development. So make sure you remember that. And make sure that you send them in properly. That little green square, no. I want that full like 8-page thing. So instead of taking and it says print results, you change it to save and then you upload it there. Anybody has any problems doing that, let me know. I'll send you instructions. If you don't understand the instructions, get with me. We'll go on Zoom. We'll figure it out together, okay? Make sure that the score that you give me is what you want. NCLEX questions, every single one is 1.25% of your grade. So if two of them, that's 2.5%. So you can see if you have less than a 78, it can pull the grade down. So make sure you at least minimum get that 78, all right? All right, that's all about NCLEX questions. In the end, week 8 and 10, I believe, there are the RN practice and assignment exams. and this is in Evolve account, make sure you don't go to the Evolve website. You must go through the modules, and it should go right into your grade book when you're done. One try. And why do we do one try? We want you to look up the answers as you're going through so that you understand. And there's like 80 questions in each. So this is right before the HESI that we're getting you prepared for it, okay? So make sure that you go through the modules, okay? Now, CJ Sims, as I said, they're not open till when your syllabus says so. I don't have them open more than that. And they want them done those weeks because they're pertinent to what's going on in the course then. There are certain things that need to be on that, what you send to me. Your name is very important, the top right corner. And then it's who the sim was, and then the date and time that it was done, and your grade. I don't have that. You'll see a 0 in the grade book, and I'll make a little message, especially the first one. Please give me da 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 da. You didn't put this here. You have till Sunday. I will not take a deduction for it unless it's after that Sunday, and then I have to give you deduction. Now there is one project. It is due week 8. It is a pediatric assessment project. Now, this is something where you choose a diagnosis. Now, when you look at the modules, it's going to have like a list of all these diagnoses. You don't have to use one of them. What I suggest, do you know someone, your child, your neighbor, your best friend, your aunt, your uncle, do they have something that's a pediatric, could be pediatric diagnosis, and you want to learn more about it? I would do the project on that. It could be virtual. It doesn't have to be a patient that you've seen, okay? Now, it's 3 parts. One is a 250-word paper, APA. Now, a lot of you don't know how to do APA. Send it to me early. It's open right now. And the first thing is let me know what diagnosis you're doing. I don't want all ADHD. I don't want all autism. I don't want all asthma. I want a good variety of different diagnoses. Every quarter, a student teaches me something. And that's what I look forward to, learning something of a new diagnosis that maybe I've never heard of before or wanted to know more about. Okay. So that's the paper. Send it to me. I'll put it in APA format and send it back to you if you give it to me early. Through this quarter, I'm going to tell you when. Here is a good time to do your paper. This is a little bit of a lean week on PEDS. This would be a great time. If you wait to week 8 and you're in community, you're going to be hit with 3 projects all at once. And you don't need that stress. I'm trying to help you do it with the least stress possible, okay? And I can help you do it. The
Are we
second
allowed to turn
part,
it in early?
yes, yes. And if you do, I will grade it, send it back, and you can increase your grade to get 100. But you've got to send it to me early. I have some students by week 4 are sending me in papers. The second part is an assessment form. It's multi-pages and it's in your modules. You just download it and then you fill it out. The end of that has some NANDA diagnoses and theorists. Now, theorists we're not going to see for the first, next week and the following week, a little bit today. So you'll understand understanding what children are like. But this child is not normal. So what would that child look like and how am I going to treat them in a hospital or doctor's office setting? Okay, that's the second part. And the third part is, let's say you tell me about a child with asthma. The third part's teaching. The teaching could be how to use an inhaler, or what medications I need to use, or what are signs and symptoms of asthma, what to do when teaching. Most students will pick the PowerPoint. You only need 5 or 6 slides. Don't give me 100 slides. That's not what I'm here for. I want straight to the point. Give me something and put references when you're done. Okay? Teaching does have to have references on it. So 3 portions. I start tell you first is the paper. Let me know what you want to do. I have to approve it. And then you start with your project. So I'm here to help you do the best you can. Always follow the rubric. Yes, always use journals that are scholarly. And then, these things are something that Dr. Brown put here. We sort of base our education on you don't hand in an assignment and we've notified you. It's not like not giving a medication to a patient or doing a treatment. Okay. And that's the way that Dr. Brown correlates things. So, and being professional. This is all part of becoming a nurse. Now, I did get this message from one of my other professors that works with me about a student who sent a message after the NCLEX. She got an 1145 on the HESI. It's not uncommon for me to have 99.99s on this HESI. Not uncommon at all. If you do what I tell you to do all quarter long, and you do what I tell you to do for the HESI, oh, it's possible. Extremely possible. But what the student says is that the CJ Sims, she kept looking things up that she didn't understand and really understood the CJ Sims, not just check the answers because you have the answers, okay? But understanding what that stuff is all about. Also, NCLEX questions, going back and looking at them and why, yeah, you can just check answers down, but why were those answers, okay? Looking at rationales, it really, really helps you start thinking a lot better. Also, the way that I teach and going into the Kahoots, I'm showing you how to rip a question apart, what to look for, and why that answer would be correct. Okay. So I'm starting to help you think. It's that critical thinking that you heard about in orientation, right? Oh my God, can I be a critical thinker? You do it every day. So we're going to teach how to do it. So that's the first part. Look at that. We got one part. Any questions so far? All right. Let's go to our PowerPoint for the day. Now, week one has chapters 26, 27, 28, 29, and 30. It's a lot of chapters, but I have condensed it into key understandings that you need to know here. Okay. Well, I mention this slide because I know many of you are going to go on for your BSN or nurse practitioner or whatever you want to be. And I know it will happen. And because I just went back to school in 2009, so it's like long ago, and I had no clue what healthy people was, I'm mentioning it to you. In fact, this is a great place to get information for your pediatric assessment assignment. You can always figure something out from this. But healthy people is all about the goals, what the government, healthcare says they want to do for children. I think the biggest one here is nutrition, nutrition always, healthy weight, tell them to get up, go out, play outside. There's been like all of the president's wives, right? The first ladies, they always have an incentive, whether to read a book or get up and move, whatever. It's all based upon these healthy people stuff. Childhood health problems, some of the big ones. Well, obesity. Well, why are children heavier than normal? Well, we stay at home, we play our iPads and our games, we eat snacks, we don't go outside, ride our bicycles, swim in the pool, and play. So if you're sitting and doing nothing, you are going to be gaining weight. Number two, this is an extremely busy environment today. Just to make bills meet is difficult. Many times you as students are so busy, drive through McDonald's, Taco Bell, wherever, and you bring home dinner, which wasn't years ago, right? Mothers stayed home and they cooked. You need two people working today and make any household going. So these things have made obesity. And then even, in adolescence, type 2 diabetes because of heavier adolescence. We know injuries, they're mostly, it's not that we try, but children, childhood injuries, falling down, getting broken arms and all of these sort of things. Your PowerPoints are all on your announcements. Every week I send them, and I'm going to send them again. I just had a question about that. Violence, we know vaping is a big thing. It's a lot better than it was. And, you have mental health problems. We think so, but you'd be surprised what I've seen. Infant mortality. Do you know that United States, we really lag behind many other countries in the amount of children, infants who die, like neonatal, first 28 days of life, than many other countries. We have a lot more to do. Now, I've been working in the newborn intensive care unit area since 1983. Do you know what changes I have seen? It's exciting to think of these little premature infants and all of the changes we have made in order to get them good quality lives and changing of the way we do stuff. So the biggest thing about infant mortality is all about how much did they weigh at birth. The smallest infant that I took care of was 575 grams. 575 grams. That is extremely small. It's less than a pound. That child made it through the grace of, I don't know, but because of the weight, there's some cognitive delays, but that child did make it out of the newborn ICU and went home. Childhood mortality, we know the death rates for children greater than one are less than infants. Well, why? Infants are born, they don't have an immune system. They've got to be exposed to diseases. They need to get their immunizations to protect them against it. So it's a big thing. Also, they are decreased over the age of one because they've built it up. They've had the cold and their respiratories and runny noses and all those virus diseases they've gotten. They've gotten immunizations like crazy. So they're protect themselves a lot better. We know those children, number one, it's that low birth weight, are going to be higher at risk. But today we have more homeless people living in poverty than we've ever had before. And also, look at that increased morbidity. Children in daycare. What do kids in daycare do all day long? They play with toys, right? What do they do with the toys? They share them. I call it they swap spit all day long. There's nothing you can do. There's nothing wrong with that. Yes, Yara.
Sorry, I don't know how to put my hand up like virtually or whatever. I know there's some like kind of option for that. But I used to work in a daycare and there was like a neighboring daycare in the area. This is like when I was 18, so like forever ago, like 10 years
Mhm,
ago.
mhm.
But this baby came to the daycare at the other daycare and like a car seat and it was like sleeping. And so the daycare teacher for the baby whatever area, she never took the baby out of the car seat and like I guess it's like airway was like compromised and it just like ended up dying and it was in the car seat like all day long and they didn't realize it. And then like the that like 10 hours later, someone's like, oh, the baby's not woken up yet. And then they realized maybe it was dead. So that's what I think of with like daycare, like associated things for like newborns. Cause
Daycares
I heard a lot more
are
stories like
actually
that.
good. Yes, that stuff happens wherever, but that's a horrible one. But is it wrong or is it bad to be swapping spit all day long? Not really. You know why? They're building up all of this immune, all the antigens. Their body has to work. And the quicker they get them in there and build their own body's defense, the healthier they'll be, especially when they get up to school age and preschool, right? We want them to be in school and they want them to learn. We don't want them home. So it's a two-edged sword there. Do I, don't I? And I get it. So thank you for sharing that. That's really scary to me. These are a bunch of things that kids do, right? They get into the guns. I live in South Florida, and swimming and drowning scares me. It's pool in my backyard. And my grandson, for the first 3 years of life, you're going to hear all about Christian. So this is part of my life, the only one who lives close. He lived with me, and when he was 2, that kid could do dives and front and back flips off of the ladder, and he could swim no swimmies, no armbands. He knew how to keep his head above water and how to keep himself safe. And today, this is this little peanut. He's still a tiny thing. He's 7 now, but this kid swims better than anything. And still, that kid is not allowed near the water unless he asks Nana or Pop Up first. And water safety is a big thing. I had a brother who burned his whole arm and even had scars there into adulthood from the pan. And we know kids like to get into pills, especially, believe it or not, their vitamins. They like to chew on, they taste good, right? And what happens when they chew on these vitamins? Well, that's when we call poison control. We get them to the ER and find out what happens. Vitamins actually aren't bad as long as there's no iron, okay? And children's vitamins don't. But if they're in grandma's, heart medicine or even Tylenol, they like to chew on them, that can cause liver damage. So again, so pediatric nursing is not just the child, it's the whole family, isn't it? I think many nurses don't go into pediatric nursing because of the parents. The parents can be challenging, and I've just learned to include them in the care. And as I'm talking to the child, I'm actually talking to the parent, teaching them what I'm doing, what I'm looking for, making the child comfortable, and now the parents knowing what I'm doing. Remember, it's family-centered care. The family is the only constant in their life, okay? They literally, um, that's all the child knows. He doesn't know any other values, any other cultures. And then you have to ask, so what the family? It's whatever they say it is. Well, the first 3 years of my little Christian's life, family, mommy, Nana, Pop Pop. That was his family. He's blessed today. He's got a beautiful stepfather and mommy, and they have their own place. But the family is whatever it is, isn't it? Be 2 women, 2 men, 1 man, 1 woman, doesn't matter. Family are all different. We try today to do things as painless as possible. We find that children don't like needles, right? We don't like to get those immunizations and they cry with it, but it's okay. I think it's sitting and letting them understand using numbing creams, distraction, giving them blow bubbles and somebody gets in the other arm, mommy holding that child before, during, and after immunizations. If anybody's worked at Nicholas Children's, I actually instituted a program called Huggies, H period U period G period, like the diaper, but it's an acronym because I put the periods. Help us give great injections efficiently and safely, which means somebody to hold that child before, comfort them, during that injection and after, and found that children were less pain, less fear, less stress, as evidenced by decrease in crying. So it's something that and it's still there today. Huggies is still part of the comfort measures at Nicholas Children. So holding the children, part of that traumatic care. All right. Chapter 27, family, as I said, they're all different. It doesn't matter what they are. We know that nurses are dealing with different cultures, different religions, things we don't know about. And remember, children are influenced by their environments that they're in, right? Younger kids at schools or friends, or as they get older, of course, at social media, of course, that stuff does influence the way that they think. So, one of the things about adolescence, a frequent health problem of migrant children and adolescents in the United States. We do have a lot of migrants, especially here in South Florida. They come in and homestead and they take care of things, and one of the big things is tuberculosis, isn't it? And it's something that we need to be aware of. Why would I, as an ER nurse at a children's hospital, have to worry about something like that? I've got to protect me, don't I? So I would put a mask on to be safe. So sometimes people with different cultures believe in different things, right? Sometimes there's foods that they eat. They don't eat meat. They don't eat chicken. They don't eat this. They don't eat that. The way they dress themselves, the way you disrobe them, all of these things are part of that person. Okay. And the one thing I've learned is that I don't have to know everything. I do not have to believe in your culture, your religion. I just have to allow you to practice that as long as it's not hurting the child that I'm in the care of, right? So we know there's times where we need to have a not have a male with a female. That some of the religions don't want a male touching their daughter of whatever age, or maybe they need time to pray, or maybe they need that healer person to come in to do whatever. I've been involved in so many different things, and it's okay because those things make that person feel better. I think one of the things is health beliefs. And, I'm this girl from little small town New York originally, moved down to Miami, and I'm with all of this culture, and I never knew culture at all. Okay. And then I had a girlfriend who was telling me, yeah, I can't wash my hair tonight because it's wet and I can't go to bed because I'll get sick. Or, oh, I got sick because I was rained on yesterday. Big thing about rain and wet. Another thing is things like my child has a fever. I need to dress them up. I need to put clothes on them because, they're sick. And I'm telling them to take their clothes off, their socks off, et cetera, et cetera, et cetera. And one of the things I've learned is many working in an emergency room. I did a lot of triage in the last 10 years of my career. And you would get these children in that were bundled up and they have a fever. And undressing them. I'm not just undressing them. I'm telling why. Why am I undressing them? Well, if the fever's here and you cover it, how is it going to go away? You need to let it get out. So that's one of the things. Also, walking on tile floor, you have to have shoes or socks on because the cold is going to make them sick. I said, well, if you have a fever, you need it to get away. And those cool floors will help draw the fever out. And when your child doesn't have a fever, don't they feel better? Another thing is things like religious beliefs. I've, worked in the cardiac intensive care unit. I opened the unit when Dr. Burke came down here back in the mid 90s. And we get these really sick babies and I don't know if they're going to make it, right? Very bad congenital hearts. And we would have baptisms come in, we'd have rabbis come in, whatever that religious person. What about blood products and Jehovah Witness? When we're talking about newborn ICU and we're talking about little premature infants, we take blood out to measure electrolytes, measure for infections, et cetera, et cetera. They're not making any blood yet. Their body doesn't know how to do it yet. So you keep pulling blood out and the hemoglobin hematocrit getting lower, lower, lower. It gets to the point where they're symptomatic. Hemoglobins of 7 and 21. Now they're apneic and bradycardic, which is symptomatic of low hemoglobin hematocrit. So a Jehovah's Witness doesn't give blood. They will not. They believe it's something about the soul of another person is being put in you. So what have I learned with that? I have given blood to Jehovah Witnesses many times. One night I did it on a night shift. And what I did is I had the parent go home and I gave it and I said, call me at this time. Yes, it was in, and your baby did well. Yes, they're not, losing their heart rate anymore. Yes, they're doing better. I've also done it on the day shift. When I come in with the blood, I have the parent get out of the room, close the curtains. I would take, put up the blood, cover it with blankets. There's no remnants of it. And then I would just look under to look at the IV site, making sure it was okay. And that parent, believe it or not, 18 years later, I met her into the ER and she remembers me and what I did with that blood. And she still wanted to hug and thank me because I did it with respect for her religion. I don't have to believe in those things, but I have to respect what that mother, that parent wants to do for their child, right? So what do you think is the leading cause of death among African American boys ages 15 to 19? Remember, they're starting to get no filter, no fear. I'm a big boy now. And it's firearms, right? They start exploring, believe it or not. Suicide might be second because adolescents, they're into body image and not liking themselves, right? So, but it's firearms. All right, let's keep going. Growth and development. Well, about an infant who's born. They're born at 7 pounds. They can't even lift their head. They can barely know how to suck, swallow, and breathe at birth. Excuse me. By 1 year old, they're tripled their birth weight and they're walking and talking. Is that amazing? 12 months. Its growth is like this interrelated, simultaneous, ongoing, and there's certain steps they take along the way. And we're going to be going over that next week in all of your um, chapter 31 in your infants. So, patterns of growth, we know it's directional, you'll get bigger. We know that they lift their head, then they turn over, then they crawl, then they creep, then they sit and they stand up and they walk. This is all, the way it goes. Now, does it mean that they have to do every single step? Many of them, maybe they won't crawl, they'll get right up and start creeping right away. All of it, as long as it's moving forward, we're doing it right. One of the things that we do as nurses is we look at their developmental milestones. If a child, let's say 6 months old, cannot lift their head up and hold it by themselves, they are delayed. So, what do? Well, we need to find out why. Is it something neurological, or do we need to put early intervention? What is early intervention? It's speech, physical, occupational therapy. So it might just be they need help with muscles in their neck and physical therapy. Occupational therapy, the same, does actually almost the same. So to catch them up. You know what the best thing about children is? They can be delayed at any of these ages. But if we give them what they need, they catch up really, really quick. And they won't be delayed by the time they get to preschool, etc. As they grow, you're going to see different things. I'm going to be sending you a handout on different vital signs. What does a baby born, what would their heart rate and respiratory rate be? Now, me, I'm 60 to 100, right? Or I'm 12 to 20 respirations. A neonate at birth, heart rate 140 to 160, at rest, asleep, fine. Okay? Respiratory rate 40 to 60, normal. Now, why do we need to know that? Well, how would you know a 1 year old if they're in respiratory distress? They're breathing at 40 a minute, a 1 year old. Is that normal or not? Well, no, it's not. That's a little bit fast. So, again, or you're giving digoxin to an infant. They have a heart rate of 100. Is that normal? No, it should be a little higher. So these are reasons why those growth and development that we need to know. And that's part metabolism. So when we are infants, heart rates are up, respiratory rates are up, and they go down to the adult. What is a normal blood pressure on a brand new baby? 60 over 40. That's the 120 over 80 adult thing. So that number gets higher as the age crawls higher. Again, you need to know those things in order to take care of infants. Are they dehydrated? Do they have a fever? Are they in pain? You need to know what those vitals are in order to make a good decision, right? Another thing is nutrition, nutrition, nutrition. If you have a car, you put gas in the tank and it goes, right? For an infant born, they are growing so quick. They need so much nutrition. And if they don't get it properly, they're going to be cognitively delayed. They're not going to be alert. They're not going to grow as much. They're not going to be developmentally where they should be because you need to give the fuel to the brain with nutrition. Okay. So, nutrition, nutrition. One of the most important things about infants, giving them proper food. Now, I mentioned a little bit about types of theorists, et cetera, right? These are the ones you need to know. Freud, Erikson, Piaget, Goldberg, Fowler. I'm going to send you a handout on this also. Which ones do we really look at? Well, Erikson will be everywhere, so will Piaget. I think the last Hesse had 3 Erikson questions on different stages. You have different expectations according to the age of the child. Infant, toddler, preschool, school age, adolescent, they all do different. For instance, the first psychosocial thing about an infant is when they cry, they know mommy's coming, right? That's what we call trust. And that's what Erickson calls it. And what if nobody goes picks them up all the time for whatever reason? Maybe it's a family, the family is a drug abuse, or there's some sort of something going on in the house, abuse. That child doesn't trust. So it's trust versus mistrust. Those are the two things, psychosocial, that Erickson talks about. Okay. So that's just the beginning of it. We're going to go in a little bit more. Now, Freud is anything about sexual, all right? Oral, anal, phallic, latency, genital. Oral is the mouth. What does the mouth do for an infant? Well, number one, they soothe themselves, right? With their mouth, whether their finger, whether a pacifier, whether a bottle, that soothes them. My husband calls those little pacifiers a soother, which is exactly what it does do. Also, what do infants do with everything? They put it in their mouth. They explore the world with their mouth. First thing is the rattle or their finger, right? That's all about what Freud says. Anal has to do with potty training because bowel training is before bladder training. They can feel the bowel before the bladder, okay? And then it goes onward, and we're going to even go more next week too. So those are the difference with Erickson, and I've just discussed them, and now Piaget. Piaget is more psychosocial. It's learning about the environment around them and exploring them. Well, first thing an infant does is, they can sort of see and understand around them, and you give them your finger or give them a rattle, they have what we call an involuntary or a reflex breath, and they grab a hold of this rattle. Then eventually they go, oh, here's the rattle again. Oh, I'm just going to grab it. And that was a voluntary. I wanted that rattle. Oh, and then it shook and I heard a noise. Oh, I like that. And I'm shaking that rattle now. They know nothing. All they can do is suck, swallow, and breathe barely. Now they're shaking a rattle and then in the mouth, right? Because now they're exploring the world in their mouth. This is Piaget. We'll go into that a lot more as we go on through them, just giving you the beginnings of it. So at birth, do children know infants know how to have a language? What do you think crying is all about? And then about 2 months, they're cooing at you, right? This is all part of the language development, and we know by 1 year old, they're saying 3 or 4 words. Could be Nana, I like that one, or mommy or daddy, right? Those things come out. Now, Kohlberg, what you need to know about Kohlberg is all about moral, right and wrong, knowing right and wrong. Infants and toddlers don't. So that's up to age 3. They still don't really know right and wrong yet. All right. And then as they get into the preschoolers, they know there's a reward for good and a punishment for bad. And it goes on up into the adolescence. But again, it's all about right and wrong, is Kohlberg. Now, children, what do they do all day long? They play, right? Whether with crayons, whether with iPads, whether with something, doesn't matter. They're playing, right? So we have made words for types of play that children do. So we can be social effective with people. Sense pleasure, that's sand, that's gooey and touchy things, right? Skill, building a block, just sitting there alone, or now we're pretend playing. And then, of course, we could play games. What does this toys and stuff do? It increases the sensory motor development. Sense is the touch, oral is the mouth, and the movement of it. It's sensory motor development, okay? It's really starting to develop the brain. And then it's making you think. Now I know I could shake and make a good noise, right? We know toys are children. It's all about socialization, playing with other children or not, being creative, and then, just being aware of themselves. I mean, I love the little kid playing in purple and gets it all over the place. That's the sense pleasure, right? It's everywhere. Now, there's types of plays, and you need to know these, okay? This is something that you're going to see on HESIs and NCLEX, and it's the types of play, and it's according actually almost to age. So onlooker is simply, I'm watching you play. Solitary, playing by myself. Now, parallel play is toddlers. What are toddlers? They don't like to share at all. They don't like you to play with another person. It's mine, me, get away. No, no, no. There is two children playing next to each other and they're not sharing anything. That's parallel play. There's nothing in the middle. They don't come together. Associative play, now it's your preschoolers, a little bit older. They're all playing together, but there's no goal to it. They're just playing. And then cooperative play, again, playing together, but there's a goal. Is it building a sandcastle or is it playing checkers and somebody wins, depending on the age of the child? So there's a goal with cooperative play. Associative, no goal, but playing together. Parallel, I'm not sharing anything. We're just next to each other. Those are toddlers. We know toys are all about, developing, you know, um, they're being creative and, experimenting. This is a time where parents can also play with them, and it's a great bonding time. And we also know with on that tummy time, toys in front of them, they're pushing, pulling, rolling, and they're trying to get there so that it's good for their developing bodies and muscles. So us as nurses, we get these children, working the last 10 years and a lot of it in the triage area. You get to the point where you can get a child, do the vital signs, do an assessment, and you know what's going on. Children in doctors' offices, nurses are the ones are with these kids all the time. We're the ones that sees those delays. This kid is 9 months old. He's not turning over yet. There's something wrong here. So again, knowing these key things, again, next week we'll go over more of it and more clearly, but just knowing that we need to know if they're progressing in the right way. And if they're not, early intervention, right? Let's give them what they need to catch them up, as kids do. We know there's all sorts of genetic things that can go on, Down syndrome, et cetera, et cetera. It's all part of it. We know that the nurse, not only are you taking care of a child, you're taking care of the family. Sometimes we have to intervene and help that bonding with children. I've seen it a couple times. What if your baby's born with a cleft lip and that mother's just afraid to touch that little baby? Well, I'm going to say, oh, God, look at that curly black hair. Oh my goodness, those feet are so big. Oh, they tickle. Get it away from that. Let the baby bond with the mother. Hand that baby to that mother, and they can hold it and look beyond that cleft lip because they don't look nice when they have that cleft lip, right? So again, promoting that attachment. Now, communication. Remember HIPAA. HIPAA is going to be there whether you're an infant or you're the adult. As a nurse, those medical records are important. The one thing about pediatrics, remember, we have children who are 18. And if they're cognitively alert, oriented, and aware, they're going to sign their own consents. And you have to ask that child, that 18-year-old, can I tell your mother what's going on here? And if they say no, you can't say anything to that mother. That's the biggest change between adults and children. Talking to parents can be hard sometimes. So we want to know, we want them to talk. We want to know what's going on. But if the child's 8 years old, I don't need to know what happened at birth, which is a normal delivery, and every single time they were sick up to that point. There's some parents who want to do that. So you need to. So what happened this time? Why are you concerned? When did it happen? When did it start? And what did you do? Okay. Another thing is be empathetic. And I'm going to give you a great example. Many times you get the young infant in, and the child is a fever or something's going on, and they've been to the doctor twice, they've been to urgent care, and they finally get to the ER. These parents are working, they've got a sick child, they haven't slept, they're exhausted, they don't know what to do. And I will say, listen, you're here now. I'm going to take care of you. Oh my goodness, you've done such a great job. You must be exhausted. It's okay. We're going to take care of this. You watch shoulders just drop like, oh, this nurse understands me. And sometimes it's just saying something like that helps a parent relax and be able to, you know, be okay with that little baby. You can't imagine not sleeping, working, and taking care of families and, sick baby, and you're just worried, right? Another thing is if you don't understand their language, remember blue phones, never a family member, because the family member will turn around what that meaning was. A blue phone interpreter, they are exactly what the parent has said, okay? So you can't go to that teenage kid and ask things. Communicating kids, sometimes it's easy, sometimes it's not. Again, always base communication on the developmental level of the child. Number one, when you go into, let's say, a toddler, ages 1 to 3, they're scared of you, right? They know that you're not mommy or daddy. And usually they know you're a nurse and you probably have an injection somewhere and they're very afraid of you, right? I sit below them. Don't ever tower above them because now you're threatening. Sit below them at least eye level. And then you're going to start talking to them based on their developmental level. Maybe it's a little 3-year-old and has a Batman shirt on. We go, oh, you like Batman? Wow, he's cool. So do you like Robin too? Or do something else? Oh, you've got curls. Those curls are great. Or wow, your eyes are so big, or your shoes light up, or whatever it is. Now you've breaking it open. With toddlers, start, playing games. So do you know where your ears are? Oh, I see if there's a hole in there. Or, oh, is that your mouth? Oh, is something in there? Oh, let me look. When you make it a game, it's going to work. And it's just taking that little time is going to save you hours of misery. Because if you don't, that kid's going to run in the opposite direction. So again, play with the kids. I said that I worked for over 25 years in pediatrics and I went to work and I played every single day. And I had so much fun with my children. Health history again, you want to know what's happening now. All right. And then initially, your assessment's going to be focused on what they're saying. If they have upper respiratory, what's the first thing you're going to do? Well, I'm going to look at them. How are they breathing? Are they retracting? Are they abdominal breathing, right? Supraclavicular retractions, nasal flaring, grunting, what's going on. And then I would listen. You never, ever, ever do a physical on an infant head to toe, a child head to toe. It ain't going to happen. Try to get in what the complaint is first and then work on the other stuff. It's not an adult. It's easier to do it in little bits and pieces. You can't just do it all at one time. They're afraid of blood pressure machines. Ever see a little 2-year-old with a blood pressure machine? They want to run in the opposite direction. We'll make it fun so that they do enjoy it. So histories, we need to know birth history, not if it was a normal healthy delivery, but maybe they were in the ICU for 2 months. That's fine. Dietary, any special diets? Are they have reflux? Do they need, little rice cereal to thicken their formula? If they've ever had any other problems before. Of course, any allergies that we know of, have they had any medications today? You're admitting them with a fever, did they have their Tylenol or the ibuprofen, right? Remember, in infants, we do not start ibuprofen till they're 6 months old. Only acetaminophen, Tylenol, for the first 6 months. And the reason is NSAIDs have something with bleeding coagulopathies, and the infants can't tolerate it, okay? So only Tylenol, acetaminophen, the first 6 months of life. Another thing that's important is immunizations. If you get a 1-year-old child in with an upper respiratory, has had no immunizations, you better put a mask on and get that child isolated. It could be pertussis, it could be anything. Okay. So, again, immunization is an important concept to remember. And then, of course, their growth, their development. Are they gaining weight? Have they doubled their birth weight at 6 months? Have they tripled it at 1 year? Do they like their blankie, their habits when they're upset? Or do they like a pacifier? Which one do they like? Which toy? Sometimes parents have to step out of the room, go home, whatever. We need to know those things to take care of those kids. As they get older, adolescence, sexual history can be important. But I know I never say anything about sexual anything in front of my mother. My mother would, I'm afraid of her. So you can have parents leave the room and you can ask that, first break open the ice again, get on the level of the adolescent, get their trust. You could talk about, oh, I heard some music playing. What do you like? Or, oh, you have a um, New York Yankees hat on. I'm from New York. Something. What do you want to be? Have you chosen college yet? Something. And once you're talking, they realize that you're just not a threat anymore. They might tell you, and you can help uh, take care of that child. Sometimes girls coming in for the third time with urinary tract infections, it could all be from sexual activity, which they're not going to tell their mother usually, right? And of course, we need to understand the family. There are some cultures that you don't speak to the mother, you always speak to the father. Okay. And you can't look them at the eyes and you can't touch them. So, again, understanding cultures and families. As we're going through, understanding about school. Are they doing well in school? Are they getting along with other children? And again, looking at the review of the body systems, remember, it's not going to be a head to toe, it's going to be as you can. Knowing what they're eating, any cultural things. You know, do they, when you have some cultures, they don't eat meat, they don't eat, they're just purely vegetarian. You would want to make sure that the dietitian knows that so they don't set up a piece of bacon for breakfast, right? Because that would be offensive to them. So, again, understanding that. And again, if you don't know, ask. Parents would prefer that. So when we have a child who is not eating correctly, find out why. Is it an infant who's always spitting up, okay, or just not eating too much, or maybe they're eating too much, some too little. Remember, a lot of times, how do we evaluate dietary? Did they eat or not? What did they eat yesterday? Right? Tell me what they had yesterday. Food diaries will always be the response here. Whenever you're talking nutrition, tell me. Food diary yesterday, 24 hours. What happened? As I said, when we looked at physical assessment, you are not going to do head to toe. You're going to do it according to the child developmental level. And again, you focus it first on this respiratory or abdominal. That's what you do first. And then see what more you could get in there. One of the things that I've found, especially with my Huggies, even doing an assessment, have them sit in the parent's lap or have the parent next to the child where you are. And that really does give them the comfort and makes the child more trusting because mommy is right there. So, which approach would be best to use to ensure a positive response from a toddler? Anybody,
Is it
toddlers,
A?
absolutely. You're definitely going to get on their level because now you're not as threatening and just talk quietly, not like yelling. They just feel calm and they're going to let you do more. And especially if they're in the mother's lap too, right? So again, excuse me. How do we get a child ready to examine them? Well, number one, having them in the parent's lap, getting down on their level, and then breaking open the ice, talking to them, playing a game, giving them stickers, whatever it takes, and get them calmed down. And then these children, I'm going to do this. Do you want to push the button or do it on me first and push the button? There's a lot of things that can be done to prepare that child. Um, they don't want to be lied to. It's going to hurt. See, it's going to hurt a little, but I'm going to give you everything I can so it doesn't hurt too much. Always with children, they'll never forget that you lied to them. So again, all the measurements, you see why we have to know certain vital signs. I want to know, what if the weight is born at 7 pounds, at 6 months, they're weighing 10 pounds. We know there's a problem there. We know the apical pulse, if it's 80 and they're 6 months old, there's a problem there, right? So these are things when we look at them head to toe. What about taking a blood pressure? What blood pressure cuff do we use? There are so many sizes. They're from 00 up to extra large, for adults. Looking at them head to toe, always look at it. You can see a lot with a child just by looking. Let me see. Head circumference, abdominal circumference are always done on infants, usually every shift, just to make sure. We're measuring heads to make sure they don't get any extra swelling or fluid collecting, because we can every shift do it and we could say, it's gone up a little bit. Let's watch that closer. Maybe they get water on the brain or hydrocephalus, right? So the abdominal circumference will tell you, are they absorbing the food that we're giving them, right? Now, in maternity, their heads are smaller than their chest at birth, right? They've got big chests and a smaller head. By about a year and a half, it should be the head bigger than or at least equal to the chest. It's another one of those developmental things. Did you ever try to put that little board on top of a child's head? Well, they think they're going to bop them over the head with it. So I would make a game out of it. I would do it first and I would put it out, oh, tenderly. Okay, and look at my number. Oh, I got a number 7. Let's see what your number is going to be. Here, you hold it. Tell me when you get it there. Oh, what number do you get? Now it's fun. They don't mind because a proper height, proper weight are important. Again, blood pressures, we do them the upper arm and we can do them all the way down. I like D, especially on toddlers and preschoolers. On the leg, it doesn't hurt as much, right? And I'm used, they're electronic today. Here, help me push the button. Here, let's do me first. And these kids will play. Now it's not threatening at all. Now, probably one of my pet peeves in nursing and in pediatrics is not giving kids enough pain medicine. We think kids don't hurt. Well, they hurt just like you and me do, but they don't know how to tell you. And also, they don't want to tell you because they're going to get a shot or they don't want that nasty tasting medicine, right? They say, no, I'm not in pain. No, I don't hurt. It really doesn't. And they're not moving. They're hurting like crazy, right? What they do is many nurses, they'll giving less than what they should get, medications, waiting long in between, not evaluating them after you give them something, and children are suffering more than they should. And what are they going to remember from the hospitalization? Pain. That's all they're going to remember. Now, there's a couple scales that we use. We're going to use faces, we're going to use FLAC, and we're going to use numeric. There's other ones, but I'm just showing you these. Now, that on the bottom is called faces, those scale. At age 3, faces is used. A 3-year-old preschooler We'll pick what face they are. And I'm telling you, they're accurate. You know what's the beautiful thing about children? They don't over exaggerate their pain. An adult, they're always a 20, right? But a child, they're going to be a 6. They're going to be an 8. They are accurate. And it's one of the things I do love about them. Now, numeric, 0 to 10, 0 being no pain, 10 the worst in the world. What are you? The book says ages 8 and older. Now, have I done it with younger kids? Yes, but the book says age 8. Now, flat. How do you measure pain in an infant or a nonverbal child? Well, by the way their face looks, by the way their legs are moving. If they're moving, their activity, their cry, and their consolability. So FLACC. And I'm telling you, it's very accurate. It works well. And again, this could be up to age 3. At 3, it's now faces. Okay? Remember that one. That you'll see again. It also could be an 18-year-old cerebral palsy child, nonverbal. You can tell flack with that too, okay? And remember using the proper scale. I mean, pain could be anywhere. It could be an earache. It could be teething. It could be surgery. It could be anything. It could be sickle cell disease, right? Having a sickle attack. All of these things. You need to be able to assess it, to be able to give them proper care. What do they need? They need medicine, and I love distraction. Turn on the TV, give them an iPad, give them a game, distract them from thinking about how much do I hurt. We know there's chronic pain. We know that there's diseases that have chronic pain, sickle cell, rheumatoid arthritis. There's things that we'll see that it's something that happens all the time, um, but that's just types of pain. We know that a child who is in pain a long, long time is going to really, they're going to be more depressed. They're not going to be as active socially or in school. They're not going to do as well because all they're thinking about is how much they hurt. So we really need to make sure that we adequately treat pain. Now, there is all sorts of checklists, all different types, but you can tell a child who's in pain. You can look at just vital signs, right? Elevated heart rate, elevated respiratory rate, grimacing, crying, they're just not moving in bed because I hurt so bad, right? And remember, there are cultural differences. I can't tell you how many Hispanic males tell their son, you're not in pain. You don't need anything. Suck up, deal with it. And I'm like, your child's about to have his arm set in a cast and he needs a little bit of something. And you try to explain it to them. But again, isn't that cultural? You'll see that in many other cultures. It's just what I saw. Non-pharmacological distraction. I've mentioned it a few times. You can distract a kid easily. I used to always carry a whole bunch of girl and boy stickers, and I would hand them out. Spider-Man, SpongeBob, princesses, whatever it is. And it would distract them from being in pain, right? We know that a pacifier on an infant is the biggest pain reliever there is. There has been a study by a Harvard neurophysiologist, I believe it was. He studied morphine and a pacifier with a little bit of sugar water on it. And what he found was there was no difference in pain relief between morphine and the pacifier with sugar water. My grandson had a circumcision with a pacifier. And after the procedure was done, we didn't hear from him. And the only reason he cried is because they had to strap him down so he couldn't move. And he didn't want to be strapped, not because of pain. So, non nutritive sucking. We also know, like this mother here, that's called kangaroo care. Now, as I said, I have many, many years in newborn ICU and cardiac ICU, which is a lot of newborns. Many times I'd put the baby onto the mother's chest. These babies in their cribs or isolates, they're just moving and they're just, oh, they can't get comfortable. Put them on mommy's chest. Their heart rates go down, their respiratory rates go down, and you can see them finally really getting some rest. Kangaroo care is amazing. Pain management is a little bit of everything. It could be initially just some acetaminophen or some ibuprofen when they're old enough, and it could go into PCA pumps as they're older. All sorts of things we can use. Know that many times it's topical. That little girl has something called EMLA. It's a numbing cream on her arm, and she's smiling, and she's about to get her blood drawn because she's not going to feel the pinch because it's numb and she knows it. We know that children who are in pain are going to have problems. So let's not do them. Again, this is where all the pain can come from, children. So, which of the following is an important factor for consideration in understanding the pain experienced in children? Which one? They maybe can't tell you where they hurt, but they'll be banging their head telling you their ear hurts or their head hurts, right? Or they'll be kicking their legs, probably telling you their tummy hurts. They're going to tell you they have pain. It's B. Why? They don't want the shot. They don't want that injection. They don't want the medicine. They will not admit it. Any questions? All right. We have a cahoots and then we'll be done. And I think we'll be done a little early, just like I promised you. Any questions so far? Are you following me okay? Not putting you to sleep yet? Okay. All right. Da, 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 da. Have you all played a cahoots before? If you haven't, what you need to do is take your cameras on your phone. Once it's loaded on that little thing, and it will go directly to the game. Just like we do for menus now. I was last year in Mexico with my daughter. And we were in these restaurants and they needed, I'm like, get the menus here. Even I didn't know how to use it. So just take your phones on the camera, click on that little thingy there. You can put your name. I don't look at these and see who had right, who had wrong. It's nothing to do with you. This is something testing you. A doxycycline. I happen to be allergic to that stuff. I get a very bad drug fever. Triad of death. Okay. Is everybody okay, or you need me to stop? All right. Our first cahoots, work one. And you will be getting this link in the announcements when I send you the recording. The leading cause of death from unintentional injuries in children is what? And I want you to know not only infants, all the way up through adolescence for many different reasons. This is always, you see any questions, unintentional injuries, what is the most? This is what you're going to see. And it's motor vehicles, believe it or not. Think about infants not put in properly or improper car seat, older kids not in their boosters, and then adolescents are now driving. So now you have more of them. So it's motor vehicle is always the number one here. And you'll see this in many different forms. Which statement is most descriptive of pediatric family-centered care? Remember, the only thing that's constant in a child's life is the family. All they know is their values, the way they do things, the way they say things. That's all they know. They don't know anything else yet. So it recognizes family is the constant. The major cause of death for children older than 1 year is how many kids climb up the sides of dressers, try to get to the TV remote control, it falls over on them. I've seen so many crazy things in the ER. But it's unintentional injuries. It's they not that we do anything to try, it's them climbing up dressers and TVs falling on them, or they're on, the playground and they fall and they hurt themselves, or a bicycle, or all it's all unintentional, but it's the reason that we do see a lot of deaths in children. The nurse caring for the child in pain understands that distraction. So remember, you can have a child in pain, you can medicate them, but when you do distraction, you can't just do anything for any child. I mean, you can't give a sticker to an infant, right? That's just not developmentally appropriate. It's more of your toddler. So it might be that infant be giving them the pacifier or talking to them and stroking their cheeks or something. Remember, it must be developmentally appropriate or it's not going to work, okay? It helps with them not thinking. They don't focus now on pain. Now they're thinking about something else. In what type of play are children engaged in similar or identical activity without organization or a mutual goal? Remember, I told you 4 different types. They're all here. Which one is it? No goal. I mean, you can play alone, you can play next to each other. That's parallel, that's toddlers. Associative is your preschoolers. They're all playing together. You're sharing toys, not a problem, but there's no goal. When they get to cooperative, that's when there is a goal. They're playing a board game and checkers, or they're out building a sandcastle together and they're building the castle. They have a goal in mind. Which statement best describes the process of critical thinking? I mean, critical thinking. So it's getting late. You're thinking about what's for dinner. You're thinking about what do you have at house that you can prepare in the time that you need to, and you have everything you need. Critical thinking. Remember, it's purposeful and it's goal directed. So you have to think, what do you need? And this is my goal. I want to have dinner on the table. So what do I have to think about in order to get that done? And that is critical thinking, whether it is a child in respiratory distress, giving them an aerosol, sitting them up, calming them down, and that helps them breathe easier. It is purposeful. It's goal directed. Same thing. What is probably the single most important influence on growth at all stages of development? Nutrition, nutrition, nutrition. If they don't have fuel in the tank, they're not going to grow, and cognitively, they're going to be delayed. Okay. Nutrition. Which function of play is a major component of play at all ages? What does play do? I mean, it could be a lot of these things here, right? So it's called sensorimotor activity. It's about touching. It's about, of course, we explore the world in our mouth as children and then moving it. And again, we are being creative. We're being intelligent is helping, but it's all about the sensorimotor activity.
What what about video games?
It's a sensorimotor. It's a motor. They're sitting there playing the video games, right? It's all about thinking, figuring something out. Three children playing a board game would be an example of what? That is cooperative play. Absolutely. Associative, they're playing together. There's no goal. Cooperative, there is a goal. Parallel, remember, that's your toddlers. They're playing next to each other, and toddlers don't share. So they're not playing together. It's one at a time with their own toys. The head to tail direction of growth is referred to as. Because remember, the head, we lift it up first. That's the first thing the child does. And then they roll over. Then they start to crawl. Then they start to creep. And then they start to walk. And it's called cephalocaudal. Well, cephalic, right, is the head. And then caudal is your feet. So it's cephalocaudal. What is the single most important factor to consider when communicating with children? It's the child's developmental level. Yes, absolutely. You know, if you get on down below, so your eye level, talk to them on their level, takes you a couple minutes, you'll be able to get so much done. If not, the child's not going to trust you. They're going to be screaming and yelling, and your assessment's not going to be good. So get on their level, and their developmental level too. What 2-year-old child pain assessment tool should the nurse use? Remember, we've talked about FLAC, we've talked about faces and numeric. FLAC is up to what age, and faces start at what age, and when does numeric start? Going to be an important concept. You're going to see it in questions. You're going to be seeing it asked just like this. And you're also going to see it in questions, which has more involved in it. You need to know what pain assessment tool. FLAC is up to preschoolers. So at 3, they become faces. At up to that is FLAC because they are not really going to be able to do the faces. All right. So by the book, FLAC up to 3, and then faces start at age 3. So it's one day before it's still FLAC. At 6 months, an infant's birth weight should do what? Mentioned it during today. You'll remember after this today. So you're doing an assessment on an infant. They were 6 months. They're born at 7 pounds. What would you expect them to be at? They should be at least almost double or around there. So 13, 15 pounds, that's where you want them. All right. What do they do by 1 year? They triple. Okay. Born at 7 pounds, 14 pounds at 6 months, 21 pounds at 1 year, minus a little bit there or plus a little bit. What would you do if they're not weighing enough? Well, they're not getting nutrition. Look at their developmental level. Are they where they should be? And then we could do things like maybe we have to add more calories to them, whether it's breast milk or whether it's formula. We can add calories, and that helps. Yes. Right.
Is it harder for if like a woman smokes cigarettes during her pregnancy, would it be harder for the baby like later on to get nutrition like in their first year to meet like the weight requirements?
Would that be hard?
Shh, be quiet, babe.
And you're breastfeeding? Are you talking about breastfeeding? When you're
Yeah.
talking about, so when you're breastfeeding, what they say about cigarette smoking, it will decrease the birth size of your infant. Once the baby's born, as long as they're getting nutrition, they still should be getting double by 6 months, triple by 1 year. It shouldn't decrease that. No, it's only the size of the baby at birth from the smoking. Okay. The first expected fine motor developmental milestone for an infant begins with. Now, next week, we're going to talk about fine motor and gross motor development. Fine motor is all about F, fingers, fine motor. And what do they do first? Remember, I said the first thing we do is we put a rattle or mommy's finger and they grasp it, and it's a reflex. And then it becomes a voluntary as it goes on. Then it goes into the little things on the little high chair, like little puff things, taking, smushing it in their face with their fingers. That is a crude pincer grasp. And then it gets where they take one at a time, very neatly pincer grasp. And that goes up to, about 8 to 10 months. All right. Fine motor. And then we'll go over gross motor too. But yes, the first thing is, yes, oh, look, the baby's giving me a hug. I put my finger in and they grab my finger. It's their reflex. Don't ever tell a mother that. Oh, your baby does love you. An 8-month-old infant should be expected to perform which fine motor skills? So the rest of the fine motor skills after we have the grasp is be able to put objects into a container. And then by 1 year, they do a block of 2 blocks, making a tower. So it goes from a reflex to a voluntary to a crude pincer to a fine pincer. And then it goes into putting things in a container or taking them out and building a block of 2. So this one right here, when we talk about a child who is 8 months old, they should be able to grasp it and do crude pincer. And then it'll become more fine as they get a little bit older, okay? So fine motor, gross motor, as you do your readings for next class. The natural physical developmental sequence that most children follow is, this is more of your gross motor. Gross motor, what did I say they do first? I mean, we know by 1 year they're going to walk. That is the first year of life. So we lift their head, then we go from the abdomen to the back to the abdomen, then we're up and we're crawling, then we're up and we're holding on the couch and moving around, and then by 1 year, either walking or attempting to walk. Now, some kids are walking at 7 months, and some kids, like my grandson, they never walked. At 15 months, they all ran. They never had that in between. And that's absolutely normal because everything was going in the right direction. Okay. Remember, no kids are the same. Which behavior indicates that an infant has developed object permanence? And it's part of next week, but I'm throwing these things in to give you these words. You'll remember it after I tell you exactly what it is. Remember, infants don't know anything at birth. They can suck, swallow, and breathe, and then they learn where their mouth is. Then you show them toys. Once they see that toy, they know there's a toy. You can hide it under a blanket. That infant will search for it. So even though it's not in visual sight right now, they'll go find it. Just like an older kid, you put the toys in the toy box. They know tomorrow when they wake up, they're going to go to the toy box and find it. That's the older kid, but same concept. Even though it's not there, they still know it's somewhere. I'm going to look for it. In general, an infant should triple their birth weight at what months? So at 12 months, we triple it. Good job. I knew you'd remember that one. Perform a head-to-toe assessment on a toddler. Most important to consider before beginning an examination. Toddler, ages 1 to 3. Remember, me, mine, no, no, no. And they're scared of you. So remember, whenever, I don't care, a toddler or an infant, a preschooler, even adolescents, number one, get on their developmental level. Break open that ice and do it in a manner that they can understand it, okay? Toddlers are hard. This is the one that you really have got to get on their level. It's almost like gaining their trust, right? Getting down, not above them, down at least eye level, and then break open the ice. And then they'll work with you. Now they think you're fun and they want to follow you everywhere. And that little bit of time saves you a lot of hassle in the long run. According to Piaget, toddlers are in the blank developmental stage. Now, I don't expect you to know this answer yet. I'm again just showing you types of questions you could see. Remember, this is all about psychosocial, right? This is all about figuring out what's going on in the world. And how do we figure these things out? Well, we touch it, put it in mouth, move it around. This is how things work. Oh, it makes a noise. I'll do that again. Oh, in my mouth. Oh, I like it. Sensor motor. This is all Piaget learning. As they get older, it's taking their hands out and being an airplane or taking a broom and now you're a horsey riding around. This is all about their mind and learning how to be creative and becoming more and more intelligent about their environment. Which intervention helps a hospitalized toddler feel a sense of control? I tell you, this is the hardest group, toddlers, ages 1 to 3. Are you going to have this child be more comfortable, not screaming and yelling and in their feet, right? So toddlers need to be on their same routine. Same foods if we can, right? Same times, bath time the same, and if they like to put on, clothes during the day and if they can with their situation, why not? All right, keep them on the same. The second thing is parents staying at bedside do help. But the first thing is absolutely keep them on the same schedule. They know what's coming next. They understand that. They're not going to get confused because they don't understand that. They want the same. All child reach developmental milestones at the same age. No, absolutely not. Absolutely not. You have children, I say they're walking at 7 months, and my kids were, almost double that. It doesn't mean there's a problem. That's normal. All children are different and unique. And it's probably one of the reasons why I love pediatrics so much, because I really have to think. Adults, same thing, all the same. Children, not at all. Immunizations for a 4-month-old infant. Which action should the nurse take to provide traumatic care for that infant? So, how do you help decrease the pain when giving it immunizations to a 4-month-old? Well, you're first going to have huggies, right? Parents are going to hold that baby. Baby's going to feel better. And you're going to give them a pacifier with sugar water on it. That's a soother. It's a comforter. They don't feel pain. Remember that Harvard neurophysiologist who did the studies, just like getting morphine, putting that pacifier in, it calms them down. Which of the following immunizations is administered to a newborn? Now, in your chapter, there's a double page, all immunizations. Some of the immunizations you need to know, I'll be going through because there's so many. This is one of the ones that is given and it's given at birth, usually before they leave the hospital, and it's hepatitis B. And then they go 2 months, 4 months, 6 months, 12 months, 15 months, 2 years, all down the line. And I'll be going over those that you need to know as we go forward, okay? But hepatitis B. And if it was to a mother who was positive hepatitis, they have a certain 12 hours before they need to give it, okay? The normal heart rate for an infant is, 140 to 160. So if they're crying, it could go up to 180 or 200, couldn't it? And as long as they're crying, that's a normal. If they are sleeping and it's 200, well, it's probably dehydration, could be fever, right? Could be pain, but usually pain, they'll be crying. But again, knowing a heart rate's important so we can evaluate and assess. What is the preferred site to give an injection to an infant? I think y'all learned that in pharmacology. And it's the vastus lateralis, which is the upper outer thigh. Again, parents can hold their child, have a nurse hold their thigh and give it. And these children, they barely even cry. It's when you take them away from the parents that they scream and yell. And then when you're done, you do bicycles with their knees, to get that immunization in there or whatever. So it'll help get that medication moved around so you don't get a big, hard, swollen, reddened area. The death of an infant under 1 year old with no known cause. What's that? And that's SID, sudden infant death syndrome. And we'll talk a little bit more about that next week. The Vietnamese mother of a child avoids eye contact with a nurse, considering cultural differences. Why? Why does she do that? Again, I'm giving you culture, right? I wouldn't have known. And it's actually respect. It's actually respect for the nurse. They don't look at you. It's part of it. I'm telling you, there's a lot of different cultures you don't understand. And as I said, if you don't know, you can ask a child who's older or ask a parent. They will be glad to tell you. A child from Mexico is hospitalized for a serious illness. The father says the child's being punished by God. Why is he saying that? And it's an absolute common health belief for the Mexican population culture. Okay. So again, these are differences in the care when you're taking care of anybody, children or adults. Which term refers to times in an individual's life when he or she is more susceptible to positive or negative influences. Again, it's one of the definitions. We'll be talking more about it next week, but I'm just introducing some of these to you. And it's actually called sensitive period. It's times where they are more susceptible. Go into it more. What is a characteristic of pre-operational stage of cognitive development? So this is Piaget. Pre-operational is ages 2 to 7. What do you think children at that age understand? They have to see it to understand it. That's concrete. When I say concrete, it's something you can feel and you can touch. It's there, it's visible. So I only know what's been shown or I've been seen, okay? Concrete. They have to see it to understand it. You can't think that they can figure things out. They don't. They have to see it the first time. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? So these are your 3 to 6-year-olds. These are your children. Moral reasoning. What's moral reasoning for these ages? So this is all about good and bad and the consequence. If I do something good, I'm going to get a reward. If I do something bad, I'm going to get a punishment. Remember Kohlberg. I mean, as we get to school age, children just like to please. They like to do good. So that's Kohlberg there. But this is typically preschooler right there. Let's see how we did today. Jay, good job, Jay. Number 3, number 2. Oxyclysine, number 2. Yay. Number 1. Justin, you took her over. Number 4, Triana and Kiara. All right, let me get out of here. So this is today's class. This is what I went over. We're right on time, like I told you a little bit earlier. So you have a moment to breathe. Any questions from anybody?
I have a question.
Sure.
So I actually was moved to a different section for this class for tomorrow. But if I wanted to still participate, like and use the Kahoots, is it the same screenshot?
If you want the same thing, send me a message and I will send them to you. Not a problem.
Okay, thank
I do
you.
not mind that. I also send all my Kahoots to all the professors, especially right before exams, so that they're all in one place. So you'll have all of the Kahoots and you'll have the study guide all combined so that you don't have to look in 16 different places. But yes, I don't care if you give them to any other students, please let's share with it for sure. So remember, you have your discussion question that is due and just your making sure that you get your module open. Anybody who needs anything, let me know. Accommodations, I need to know as soon as you possibly can. Send me that letter so that I can make sure that I give you what you deserve, okay? And if you want anything, send me a message and I'm here for you. I will send you the recording out later on, and I'm going to attach those couple things I told you about. The vital signs. I'm going to attach about the theorists. Also, anybody who's not good at dosage calc, I am the dosage calc queen. I can teach you, make it easy that you've ever seen it, and I can teach you quickly. All right? It is not a ratio proportion analysis or whatever those words are. It is simplistic. It shows you how to pull out what you need. I also will send you for every exam sample questions that you can go and you can review. And if you could do those questions, you'll be able to do those on the exam, okay? So I do everything to help you. Again, anything you need, if you need help, just holler and I'll work with you. Nice meeting you all, guys. If you know what your project is already, send me a diagnosis and you can start working on it. Take care, guys.